Hi, my name is Mayur Muganathan, and I'm the Data and Reporting Strategy Manager in the Healthcare Variation team at the Commission. Today I'll be demonstrating how you can use the Australian Atlas of Healthcare Variation to see how dispensing rates for opioid medicines in your local area compare to national, state and territory, and other local rates. I'll also show you how you can use this data to identify potentially unwarranted variation in prescribing patterns in your local area. As part of its work in improving safety and quality in healthcare, the Commission produces the Australian Atlas of Healthcare Variation. The Atlas uses maps and graphs of variation in care derived from information routinely gathered by the health system to show how use of healthcare differs depending on where people live, how their care is funded, and their level of socioeconomic disadvantage. The Atlas includes a range of indicators across primary care and acute care settings. Data is available at a national, state and territory, PHN, and local SA3 level. The Atlas is not a performance measure, but merely a tool to prompt further investigation into whether the observed variation is warranted. In September 2022, the Commission released a report on opioid medicines dispensing. This time series report examined rates over a 5-year period from 2016-17 to 2020-2021. There was an 18% reduction in opioid medicines dispensing rates nationally over the 5-year period. Rates also fell across all states and territories. There was a 30% reduction in the overall volume of opioid medicines dispensed, and dispensing rates were generally higher in regional areas compared to major cities and remote areas. And rates increased in areas with socioeconomic disadvantage for each of the 5 years. There was little change in the magnitude of variation over this 5-year period, and the number of medicines dispensed was around 5 times higher in the area with the highest rate compared to the area with the lowest rate. Once you're familiar with the national trends, either by viewing the data visualizations or reading the clinical commentary, you can understand how your local area compares by examining the data at a primary health network or SA3 level. Here we have an example of data for a de-identified primary health network, filtered by socioeconomic status and remoteness category, taken from our recent opioid time series report. This graph shows SA3s within a primary health network classified as a major city and within the 4th socioeconomic quintile, marked here. This bucks the trend where we were seeing higher rates in inner and outer regional areas and areas with more socioeconomic disadvantage. Ideally, this would indicate that more investigation is needed to understand the reasons for why this variation is occurring. Identifying unwarranted variation represents an opportunity for the health system to improve. If unwarranted variation is identified, a range of tools and resources are produced by the Commission to help you act to address this variation. These include our user guide for reviewing clinical variation in healthcare, which presents a 6-step approach to review where variation might be occurring within your services, and case studies that show how local health services are using this guide in order to improve clinical care. Action 1.28 of the National Safety and Quality Standards requires health service organisations to identify potentially unwarranted variation and regularly review and improve the appropriateness of clinical care. Our clinical care standards support evidence-based care and measurement of quality improvement. Thanks for your time today. I encourage you to visit our website and review the resources as discussed, and have a look at the opioid medicines dispensing time series report in more detail. Thanks again.
Hello, I'm Steve Waller, Senior Product Officer for Medication Without Harm at the Australian Commission on Safety and Quality in Healthcare, and I'm here to talk about the opioid analgesic stewardship in acute pain clinical care standard and how it underpins sustaining use of opioid analgesics. Let's examine the problems that prompted the development of the clinical care standard. Sending home patients after surgery or from the emergency department with just-in-case opioid analgesics can lead to persistent use. Persistent use for longer than 90 days is reported to occur in 3.9% to 23.6% of patients who have had surgery. Each refill and week of opioid analgesic prescription is associated with a large increase in opioid misuse amongst opioid-naive patients. And further, 1 in every 13 people who start on weak opioids progress to stronger opioids. It is well established that persistent use of opioid analgesics can produce tolerance, dependence, and addiction, and can lead to diversion. The clinical care standard is an important part of the solution. It aims to prevent new cases of opioid analgesic dependency in people presenting to the ED with acute pain and for inpatients treated for post-surgical acute pain by changing the behaviour of prescribers and following stewardship principles. It requires clinicians to reflect on how they use opioid analgesics, modify their reflex prescribing, and follow appropriate prescribing best practice to relieve pain and improve function. The clinical care standard seeks to align clinicians' actions with its evidence-based recommendations, such as ensuring appropriate dose and duration of opioid analgesics and limiting the use of modified release opioid analgesics for acute pain. There are 9 quality statements that guide best practice, everything from shared decision-making through assessing acute pain, analysing the risk versus the benefit, exploring pathways of care, prescribing opioid analgesics appropriately, monitoring and managing adverse effects, maintaining a record, and reviewing therapy. The last quality statement addresses transfer of care, recommending planning for appropriate analgesic use at the transfer of care, beginning when a patient is started on an opioid analgesic during their hospital visit. It should be according to an agreed opioid analgesic weaning and cessation protocol, and the number of days supply of an opioid analgesic on discharge is based on multiple factors, including the expected course of the patient's condition, appropriate arrangements for follow-up, and opioid analgesic use in the last 24 hours before discharge from hospital. The Commission has developed resources to assist with implementing opioid analgesic stewardship. Examples shown here are the Clinical Care Standard, a guide for consumers, a fact sheet for clinicians, and information for health service organisations. The Clinical Care Standard and other resources are available on the Commission's website. The website link is above the CCS and the fact sheets. To summarise, appropriate use of opioid analgesics underpins medicine's sustainability. It does this by addressing inappropriate use for chronic non-cancer pain, just-in-case prescribing and supply, and prescribing and supply after function has returned. And as a result of these things, the risk of opioid-related harm is reduced. Following the Clinical Care Standard ensures opioid analgesics will be available to treat acute pain indications into the future. This demonstrates the safe and quality use of medicines ensures medicine's sustainability. Thank you for your attention today.
Thank you for the opportunity to present on perioperative opioid stewardship programs and post-surgical opioid prescribing in this lightning session. I would like to acknowledge the traditional owners of the land from which I am presenting today. I have no conflicts of interest or commercial relationships to disclose, but I am grateful to the Ansgar Research Foundation for funding some of my work that I'm presenting. Opioid analgesia is a core component of effective pain management, but unfortunately involves therapeutic risk. Therefore, the benefits of opioid analgesia for acute post-surgical pain needs to be balanced with the potential for opioid-related harm. From the early 2010s, there was increasing awareness rising from the US of the transition some patients were making from prescribed therapeutic use to dependence and illicit use with associated harm. Stewardship is a clinical governance initiative applied to medication at risk of causing harm but that cannot readily be excluded from practice. US literature has demonstrated excessive perioperative prescribing, suboptimal patient handling, and persistent opioid use post-surgery as some of the drivers of the opioid crisis. However, even as the extent of the problem was becoming clear, there was awareness in Australia of the differences in the health system compared to the US, and the uncertain applicability of US data to Australian practice. To inform the local situation, Australian researchers started assessing practice in their institutions. Along with my colleagues, I investigated the situation in Victoria in our study of 4 hospitals. We reported the rate of discharge opioid prescribing in a mixed surgical population, and that the patients most likely to receive discharge opioids were younger, healthier, and having painful surgery. In our cohort, we also found excessive opioid prescribing and suboptimal use and handling, suggesting that Australian perioperative opioid practice was not ideal. We currently lack any truly national, broadly representative data on perioperative opioid practice, but we have enough data snapshots to be confident that measures to optimise perioperative opioid practice are needed. Just as the post-surgical opioid practice was unclear until local literature became available, the mitigations being used locally were similarly opaque. To address this, I, along with my colleagues, surveyed anaesthetists across Australia and New Zealand, mainly in public hospitals with acute pain services. A range of opioid stewardship measures were in place at the time that this survey was conducted, several years ago now, but it was uncommon that comprehensive stewardship programs were being reported. This is a schematic of the opioid stewardship program we introduced into 3 hospitals in Victoria following the reporting of practice in our baseline cohort. The core components were adapted to local workflows. We then recruited a post-program cohort to re-explore perioperative opioid practice. Whilst there were some improvements to practice, such as a reduction in the oral morphine equivalents dispensed without an increase in resupply requirements, some suboptimal practices persisted, particularly lack of disposal and some diversion. So are these measures working to improve patient safety? In Australia, the total opioid prescription, opioid-related hospitalisation and pharmaceutical-related opioid deaths, as shown by the top dark green line, have been falling over the last 5 years. This is encouraging, and it would be lovely to attribute this to individual opioid stewardship measures entirely, but we need to account for additional powerful and related levers for change, guidance and regulation. In 2021, Levy and colleagues published an international consensus statement on perioperative opioid practice, which provides specific and actionable guidance on risk factors for persistent postoperative opioid use and recommended perioperative measures to address these. Beyond guidance is regulation. Last year, the Australian Commission on Safety and Quality in Healthcare released a clinical care standard on opioid analgesic use in acute pain. This development highlights that it's an emerging priority area for the health system and may help to accelerate change in the field. In conclusion, perioperative opioid stewardship has great potential to improve prescribing, handling, and patient care. Currently, variable practice and incomplete programs likely exist, and there is a dual role for local and regulatory measures going forward. But I want to leave you with the message that this work is a high-stakes area. Behind every measure that seeks to reduce access of surgical patients to opioid analgesia, with the very good intention of optimising patient care and reducing community opioid reservoirs, there is absolutely a critical need to have rescue mechanisms for patients experiencing distress. Perioperative opioid stewardship pathways can guide the care of the many, but our expert pain medicine physician colleagues are vital to provide the specialist care for the few who require it.
Today, I'll be answering the question, does opioid type affect persistent postoperative opioid use? First, some background. This year, 1 in 6 Australians will use an opioid. Of these, 50,000 will go on to develop what is known as persistent postoperative opioid use, or PPOU, which occurs when patients continue to use opioids more than 3 months after being discharged from hospital following surgery. PPOU is associated with a wide range of often overlooked but impactful adverse effects such as constipation and endocrine disturbance. These patients also go on to have worse surgical outcomes during later surgery. Significant time and resources are spent managing these patients, and all of this is for little to no demonstrable benefit in pain reduction when compared to simple analgesia in the management of long-term pain. So, to answer our question, does opioid type affect PPOU, we conducted 2 big data studies using linked hospital and community pharmacy data. We had over 120,000 participants who underwent surgery at 4 private hospitals within Australia. The first study aimed to determine whether the opioid type prescribed at discharge influenced a patient's odds of developing PPOU, whilst the second study aimed to determine if pre-surgical opioid type affected odds of PPOU in opioid-experienced patients. That is, for patients who already used opioids before surgery, did the opioid they were using prior to their operation influence whether or not they continued to use opioids 3 months after surgery? We focused on oxycodone and tapentadol as these are the 2 most commonly prescribed opioids in Australia, and we split the study into 2 groups for analysis, an all-surgery study group and a smaller orthopedic surgery group. So whilst not the primary aim of our study, perhaps the most significant finding was how opioid formulation, that is, whether an opioid is an immediate release opioid or a modified release opioid, impacts the likelihood of a patient developing persistence. Over on the left, we have the results for opioid-naive patients, and we can see that modified release opioids like Targin were associated with 5 times higher rates of persistence compared to their immediate release counterparts. And for patients who are opioid experienced, rates of persistence were 50% higher with modified release opioids compared to immediate release formulations. These findings align strongly with the Australian and New Zealand College of Anaesthetists' position statement that long-acting opioids are associated with persistent opioid use and a number of other adverse effects. Now looking at the main focus of the study, does the opioid type at discharge affect odds of persistence? This table shows the odds ratios for discharge with tapentadol compared to oxycodone in various study groups. We can start by focusing on the red box in the bottom left. This represents the typical orthopedic patient who is opioid naive and discharged on immediate release opioids. For this group, discharge with tapentadol was associated with 0.51 times the odds of PPOU as discharge with oxycodone. Although this represents a reduction of persistence of almost half, this is still less impactful than the 5 times less persistence seen with the prescription of immediate release opioids compared to modified release. For this reason, the results for the modified release columns are less relevant. Interestingly, there was no significant difference between discharge with tapentadol and oxycodone in the immediate release all surgeries group. We hypothesize this may be due to the 4.5 times lower risk of persistence in this group. Now finally, we also looked at pre-surgical opioid type, that is, whether the patient came in on oxycodone or tapentadol prior to surgery. We found that pre-surgical opioid type did not affect risk of persistence, but that pre-surgical opioid dose did impact risk of PPOU. So, in conclusion, many factors of opioid prescribing influence a patient's risk of continuing to use opioids 90 days after surgery, and a multifocal approach of opioid stewardship is required. Our research adds to the currently available literature by demonstrating the increased rates of PPOU associated with modified release opioids at discharge, and demonstrating that amongst orthopedic patients, tapentadol was associated with around half the risk of developing PPOU. However, pre-surgical opioid type was not associated with PPOU. Thank you.
Hello, my name is Ailey and I'm a postdoctoral research fellow at Monash University. Today I will be talking about the evidence-based clinical practice guideline for deprescribing opioid analgesics, a national guideline developed at the University of Sydney, led by Associate Professors Daniela Niddick and Carl Schneider, and myself during my PhD candidature. In recent decades, we have observed significant increases in harms and deaths resulting from both prescription and illicit opioid use. In response to this opioid crisis, the Centers for Disease Control and Prevention in the United States of America released a guideline in 2016 with recommendations to promote more judicious opioid prescribing. And although it presented much needed guidance for healthcare professionals, unintended harms were also observed, including patients being abruptly cut off from their opioid therapies, resulting in withdrawal symptoms and pain crises, as well as increased rates of suicide and illicit opioid use. Actionable and evidence-based recommendations about when and how to safely de-prescribe opioids were required. Deprescribing is the process of medication dose reduction or cessation when the harms of a particular therapy are deemed to outweigh the benefits. And in the context of chronic non-cancer pain, we know that long-term opioid therapy has only minimal beneficial effects on pain and function, but is associated with significant risks of harm. And if that is the case for an individual, deprescribing may be appropriate. However, evidence on the benefits and harms of opioid deprescribing required systematic evaluation and interpretation by experts in order to make evidence-based recommendations. So we assembled a 17-member multidisciplinary guideline development group comprising healthcare professionals, researchers, and consumers to begin the development of our guideline. We generated 3 key clinical questions. Firstly, what are the benefits and harms of opioid deprescribing? What is the best approach in terms of how to deprescribe opioids? And which interventions are effective for opioid deprescribing? To answer this, we conducted qualitative interview studies, both with healthcare professionals and people who take opioids for pain. And then we conducted evidence syntheses and appraisal, primarily using an overview of systematic reviews. We then applied what is known as an evidence to decision framework, and this really allowed us to consider a range of contextual factors that may influence the implementation of our recommendations in practice. We ended up generating 11 key recommendations about when not, and how to deprescribe opioids. I don't have time to go through all of them in great detail today, but to summarize, our recommendations advocated for planning for opioid deprescribing at the point of initiation. We identified particular clinical characteristics or time points that may prompt consideration of deprescribing. And we also recognized times where it may not be appropriate to deprescribe opioids, including for people who are nearing the end of life or people with severe opioid use disorders. In terms of how to deprescribe opioids, there is a real emphasis in the recommendations on shared decision-making and developing and tailoring deprescribing plans to meet the clinical characteristics and goals and preferences of the person taking opioids. Following a 60-day public consultation period where we received 40 responses from individuals, organisations and state governments, we refined our recommendations and the guideline based on this feedback, and then we sought approval from the Australian National Health and Medical Research Council. The NHMRC approved our guideline recommendations in September last year, which indicates the robust methodological processes that we adhered to during guideline development. And additionally, you can see on the screen that the guideline received endorsement from a range of national and international professional organisations. If you're interested in finding out more about this work, we have published a summary of the guideline in the Medical Journal of Australia this year, and it's open access for you to download. Our team's next steps will really be focused on how to optimally implement the guideline in practice and support safe and appropriate deprescribing to reduce opioid-related harm. Finally, I would like to acknowledge and thank the many wonderful people who contributed to this program of work, particularly my PhD supervisors Carl, Daniela and Christine, as well as our wider guideline development group. Thank you.
Hello, my name is Christian Harron and I'll be talking today about our study on pre-transplant opioid use and lung transplant recipient outcomes. It is a single-centre retrospective record review done at St Vincent's Hospital with Dr. Jennifer Stevens. Lung transplantation carries the highest mortality rates of all solid organ transplants, with just 1 in 5 recipients not surviving beyond 1 year and 2 in 5 beyond the 5-year mark. It is therefore important that we have appropriate selection criteria and awareness of risk factors that predict more successful outcomes, particularly in the setting of ubiquitous organ donor shortages worldwide. Opioid use has been identified as a negative risk factor in many organs such as heart, kidney, and liver transplant recipients, such as increasing postoperative opioid requirements and mortality rates. However, there is a lack of understanding in lung transplant recipient outcomes. Currently, there is still no specific information on opioid use in the International Society of Heart and Lung Transplantation guidelines. As such, we undertook a study that wanted to answer the following questions. Does opioid use increase respiratory infection rates within 12 weeks? Does opioid use reduce graft rejection rates? Our secondary objectives are whether they increase length of stay and rehospitalization rates, mortality rates within 12 weeks, and the post-operative opioid requirements within the first 7 days. To do so, we performed an audit of all lung transplant recipients from January 2018 to 2020 at St Vincent's Hospital. All baseline characteristics were extracted from both electronic and paper medical records, and recipients were categorized as either opioid exposed or non-opioid exposed, and then were compared. Within this 2-year period, there were 109 lung transplant recipients, with 13 of whom had opioid exposure prior to transplant. An overview of the results. It showed an increased rate of infection with a 1.5 odds ratio, an increased mortality rate and increased rehospitalization rates, as well as a decreased graft rejection rate. The post-operative opioid requirements were also higher in the opioid exposed group by roughly 80%, which reached statistical significance. The study's outcomes support both clinical concerns and the literature of other organ transplant outcomes. The greater rates of infection, hospitalization, and mortality within 12 weeks, as well as reduced rejection, may be due to the immunosuppressive characteristic of opioids, as well as the respiratory suppressant effects of opioid use. As expected, the opioid exposed recipients had almost double the post-operative requirements, perhaps due to the effect of tolerance. Given the small cohort with just 13 recipients in the opioid exposed group, this had limited power with several confounding variables, as multivariate analysis was unable to be performed given the small sample size. As such, we are currently undertaking a larger project with Alfred Hospital in Melbourne for a larger cohort study, a centre who does have a higher proportion of pre-transplant opioid use, and this will help to both provide greater power for our study, as well as observe any differences between the centres. Thank you.